Good afternoon, everyone. Sorry for the technical glitches. Myself, Dr. GAZAL PATNAIK, and I shall be discussing about a very rare topic. Till now, we have discussed about infectious versus non-infectious causes, and we also saw the importance of keeping in mind the possibilities of masquerade syndromes while dealing with a case of uveitis. But first, we need to see whether the case is uveitis at all or not, meaning non-neoplastic syndrome. So as we have learned, uveal masquerade syndromes are a group of disorders that mimic intraocular inflammation but are non-inflammatory in nature. So basically they are of two types, neoplastic and non-neoplastic. We will now be focusing upon non-neoplastic variety. So when a patient comes to your OPD with something like this, immediately what comes in mind is HLA B27 or B5 or endophthalmitis or even masquerades in our mind, and we start taking history regarding joint pain, back pain, recurrent orogenital ulcers, and etc. What is equally important is taking a drug history. So this was actually a rifabutin-induced hypopian uveitis, and the stoppage or cessation of the drug helped the patient. Similarly, another such patient came with mild vitreous haze, inferior snowballs, and this patchy retinal vasculitis. All the systemic workup for sarcoid and TB were negative, so the patient was actually etanercept-induced sarcoid-like uveitis. So these are all the drugs that are capable of causing what is called as drug-induced uveitis. So drug-induced uveitis have a very extremely low prevalence, and this may be due to underreporting of the cases. The exact etiology remains largely unknown, and it could be due to direct as well as indirect mechanism. Direct, when the drug has a direct access to the intraocular tissues, we see anterior uveitis, especially in some patients with multiple intravitreal injections. So these are drug-induced direct mechanism where it eventually leads to breach in the blood-ocular barrier, resulting in ocular inflammation. Indirect mechanism includes deposition of immune complexes or an immune reaction to antigens or alterations in the scavenging mechanism. So we have learned that drug-induced uveitis can mimic uveitis in any form, from anterior uveitis to pan-uveitis to even scleritis. This was another patient who was treated for recurrent anterior uveitis, but on a closer look we see these were actually pigments and there were stromal atrophy of the iris. On a simple gonioscopy we can see there were heavy deposition of the pigments in the trabecular meshwork all round. So this was a case of pigment dispersion syndrome and not actual anterior uveitis. This patient also had a drug history of systemic moxifloxacin and was diagnosed as bilateral acute depigmentation of iris post-COVID infection following systemic moxifloxacin. Similarly, another case of recurrent anterior uveitis recalcitrant to any therapy. This was actually a case of intraocular foreign body, and the clue lied in peripheral retinal examination showing the impaction of the foreign body site. What is most notorious is those found in the angles. Another similar patient came with retinal detachment and was treated elsewhere with corticosteroids. The patient had a relief, but again to recur to us with a increase in the retinal detachment, and when we saw the periphery we see this dialysis. So this patient does not need corticosteroid but needs a urgent vitreoretinal surgery. Another elderly patient with this vitreous haze, recent onset, and complaints of headache and blurring of vision. The first thing that we need to rule out, we are afraid of, is primary intraocular lymphoma as discussed earlier, or even multiple sclerosis. But on a closer look, we can see this ring-like structures, which is actually an evolving posterior vitreous detachment. So it is known to cause an increase in cytokine levels in the aqueous humor. Another 52-year-old diabetic male walks to your clinic with this severe exudation and hemorrhages in one eye. We suspect as diabetics are usually immunocompressed, we suspect maybe some viral etiology or something. All the workup, everything was normal, vasculitis workup, everything normal. But a simple serum lipid profile revealed a highly deranged triglyceride levels, and the patient was diagnosed as diabetic retinopathy, lipemia retinalis. Similarly, another female walks to our OPD with this type of disc edema, hyperemia, and subretinal fluid and exudation. What we need to pay attention is this cotton wool spots. So all the systemic worker was okay. Here comes the importance of history taking. So the patient gave a history of preeclampsia with intrauterine fetal death. So this was a case of hypertensive chorioretinopathy. So institution of corticosteroids or any immunosuppressive would have further aggravated the situation. Another case of a young male with unilateral, this type of subretinal lesions with ILM folds and everything in one eye, very anxious patient. He was treated with corticosteroid elsewhere since 6 months, but the vision did not recover, so came to us. On OCT and FFA, we could very well see that it was a case of central serous chorioretinopathy. A simple fundus examination would have also delineated that, revealing this central clearing of the lesions. And just the stoppage of the corticosteroid helped the patient in just 6 weeks. Another similar patient, but this time with a severe inferior retinal bullous detachment, similar macular features like earlier case, and this FFA OCT helped again. Again, that central clearing of that lesions would have also helped the physician to know that this is not a choroiditis that needs corticosteroid, but rather to stop corticosteroids in any form. The clue also lied in other eyes OCT, which showed a pigment epithelial detachment. So non-neoplastic uveal masquerade syndromes is not a much analyzed entity, although those who have analyzed have found that amongst the uveal masquerade syndromes, 53% and another paper, it was 45% that is non-neoplastic in nature. We just need to pay more attention. So few characteristics that are associated with non-neoplastic variety are, there is a delay in time period from symptom onset to final diagnosis of around 30 days. Even some patients have 6-month delay, as we saw in 2 cases of ours. Secondly, systemic complication is also very high. Around 29.2% have exhibited unidentified systemic conditions like diabetes, high serum triglyceride levels, and preeclampsia. Thirdly, and the most important, is the role of multimodal imaging and the systemic checkup. With the advances in multimodal imaging, more and more number of non-neoplastic varieties could be discovered. So what is to pay attention here is when we compare with non-neoplastic with the neoplastic, we see the macular involvement is quite higher in cases of non-neoplastic. So we need to pay more attention, otherwise that would jeopardize the macular function of the patient. Again, the systemic and the multimodal imaging helps delineate non-neoplastic very easily as compared to neoplastic. So in a nutshell, retinal vascular disorders are more commonly misdiagnosed as retinal vasculitis, but we need to have a close follow-up, close checkup, and history is very crucial in these cases. We'll brush up a little bit with this case of a young male with inferior retinal detachment, little bit of hyperemia of the disc, complaints of blurring of vision and headache, simultaneous onset for 2 to 3 weeks. Other eye, no, okay, suspecting all the OCT, FFA, everything was done, suspecting it to be atypical leakage or something. The patient was started on systemic corticosteroids. However, after 1 month, there was resolution. The patient also had choroidal detachment. So there was resolution of choroidal detachment, but the retinal detachment remained as such. So this made us to revisit the diagnosis again. In the meanwhile, the patient also developed this type of leopard spot retinopathy. So we were a little scared, young male unilateral leopard spot retinopathy. We had a systemic workup done with PET scan, MRI, everything was normal. There was no clues for any malignancy. OCT showed this type of bumpy RP folds with subretinal fluids and the shaggy photoreceptor disruptions. So again, in this patient, what came in handy is again another ocular imaging modality, which is ultrasound biomicroscopy in this patient that showed suprachoroidal effusion, and this was a patient of uveal effusion syndrome. So in a nutshell, never overlook the history, like drug history, trauma history, or family history. Never forget the peripheries, especially with the gonio and the peripheral retina. Unusual presentation or the responses should always raise a suspicion. Always have a close follow-up if you are starting the patient on corticosteroids. Don't get biased with the initial good response with the corticosteroid, because that may reduce the secondary vascular inflammation that these diseases might cause. But or maybe the natural disease course, like in central serous chorioretinopathy. So we need to be very suspicion of any unusual presentation or responses. Imaging plays a very pivotal role, and systemic examination is very, very, very important. Thank you.